And I'd like to welcome to the stand now Professor Fran Game, who is a consultant diabetologist in the Midlands and has an international reputation in the field of the diabetic foot. And funnily enough, this is another car conversation I've had about the role of heel casts, so you're both proving very useful to me today. But isn't it great when you get research that actually answers clinical questions, things we're thinking about? So thank you very much. Over to you.
Thank you, and I'd like to thank the organisers for the invitation to talk about my favourite subject, which is ulcers in patients with diabetes. And I'm just going to digress from the heel momentarily to say to you that it is not inevitable that every patient with diabetes gets a foot ulcer. That there is a progression to becoming ulcerated from having poorly controlled diabetes, poorly controlled cardiovascular risk factors, to developing those risk factors of neuropathy, arterial disease, deformity, and then potentially to ulcerate. And there's always a trigger to ulceration, and in the UK that's usually footwear. Unfortunately, if they do ulcerate, they may go on to amputation. I show this slide because actually this stairway gives us the opportunity to step off at any one stage and potentially prevent the amputations that we've heard about and the poor outcomes that I don't have to tell you about because Andrea just has. However, despite the fact that only 2% of our patients with diabetes will be ulcerated at any one time, the burden on the NHS is vast. This is all ulcers. So this is annual data from HES data across England, and just scanning down that, you will see that there were over 1 million nights in hospital due to diabetic foot disease in the year 2014 to 2015, and that currently the annual amputation rate per 1,000 patients with diabetes is about 2.6. Now, this fancy chart actually we developed in the East Midlands to give to CCGs just to tell them what their amputation rates were and are and have been, but we produced one for all of England just for information. You probably can't see it very well, but it actually shows that things are getting worse, not better. That actually the total number of amputations in England has actually increased between 2009 and 2015. That'd be major amputations, particularly minor amputations. And all of the rate of major amputations seems to have gone down from 1 to 0.8 per 1,000 patients with diabetes. What you've got to remember is there has been a huge increase in the number of patients who are being screened for diabetes at the early age of their disease when they don't have neuropathy and arterial disease and are therefore not at risk. So we have to be aware of looking at uncomplicated patients. And obviously this is very costly. These data were produced in 2012 by Diabetes UK and have just been updated this year. And now the cost per annum to the NHS of diabetic foot disease is around £1 billion. And you'll see that the majority of that is actually in primary community and outpatient care, the care of ulcers. And so if we can shorten the time that a patient has an ulcer, then the savings are potentially vast. It's not just about inpatient care. And heel ulcers are the worst end of the scale for our patients with diabetes. If a patient has a heel ulcer, the length of time it takes to heal on average is much longer than on any other part of the foot, on average 200 days. Now on any other part of the foot, on any other weight-bearing area of the foot, we would offload a patient with diabetes. We'd take the pressure off it with a fancy offloading device. And this is David Armstrong's classic study where he compared a total contact cast with a half shoe and an air cast walker, and those patients that had non-removable offloading, 90% of them had healed in 12 weeks. The problem with the heel is that that doesn't work. Various studies have shown that actually you put a patient in a total contact cast, the healing time is exactly the same. So we're stuck with patients with the ulcers of the heel. What we traditionally do doesn't work. Now, just to make matters even worse, as if I haven't painted the picture badly enough, every year there's this National Diabetes Inpatient Audit. These are the results of 2016. This is a snapshot. So on one day in September, every patient with diabetes in the majority of trusts in the UK gets screened for things like how high was their blood sugar, how low was their blood sugar, did they go hypo, were they getting the right food, but they also look at did they have their feet examined. And at the bottom there, you can't read it, is that 1.3% of patients with diabetes developed a heel ulcer during the hospital stay. So we have got a terrible problem with prolonged healing, high cost. Now, this report was, trumpeted in the fact that we'd halved the rate of inpatient heel ulceration between 2010 and 2016. 1 in every 100 patients admitted to hospital gets a heel ulcer, and the associated costs of that are vast. So we got quite excited in 2008, the Diabetic Foot Study Group of Europe, because we saw this poster describing this device and suggesting that it improved healing times of patients with diabetes. So this was a soft cast heel cup made of a single layer of soft cast and reinforced over the site of the ulcer, molded to the patient's heel. And they described a series of 50 heel ulcers. They weren't all diabetic, but all had peripheral arterial disease, and showed a median time to healing of 6 weeks. 6 weeks! When the average time was 5 months normally. We thought this was just awesome and seemed to be very easy to do. And so we undertook a formal evaluation of this, comparing standard best practice care, given the fact there's nothing specific for heels, with a heel cast in one group versus standard care alone in the other. And this was funded by the NIHR HTA programme. This is actually the formal title of this, and this is the people who were involved. Myself and William Jeffcoat were co-CIs on this, and it was run by the Nottingham Clinical Trials Unit. So it was a randomised observer-blind trial, so single-blind. Patients had an equal chance of being randomised to the intervention or usual care, and it was powered to detect a difference in healing at 24 weeks from 40% in the usual care arm to 55% in the treatment arm. I mean, nowhere near the effect that the original pilot had shown. And we undertook this in 35 specialist diabetic foot services in the UK. So it's patients with diabetes, aged over 18, with grade 2 to 4 heel ulcers. Importantly, all patients had to be able and willing to give informed consent. The ethics committee would not allow us to include patients who could not give informed consent, who'd lost capacity, although we know that that population is probably at higher risk than any other. And those were the exclusion criteria. Our primary outcome was healing, which was identified on or before 24 weeks from randomisation, and we predefined that as full epithelialisation, which had to be maintained for 4 weeks and was confirmed by an observer blind to the randomisation group. So what we had to organise in every centre was that there was 1 or 2 people who were not involved in the trial, who were wheeled in at appropriate points to say yes, it is or isn't healed, but had no idea what the intervention was, and the patients were told not to tell them. Our secondary outcomes were time to healing, change in ulcer area. We had to use acetate tracings because of the difficulty of taking digital images of ulcers that go around corners. Infection, major and minor amputations, recurrences, ulceration on the other limb, and that's very important in any trial of offloading. Does it cause rubbing on the other side? You just move the problem. Pain, because actually the original pilot study suggested there was very prompt pain relief in any patient that had pain. Quality of life, hospital admissions, death and other adverse events. This was the schematic of the trial. I'm going to put this up to show you that it was 24 weeks, patients were seen 2 weekly. There was a blinded assessment at any point that the investigators thought that there was healing, but in addition we pre-specified blinded healing times halfway through and at the end. So this is a consort diagram. There were 1,800 patients screened. Actually, I'm sure there were more than that. But anybody who's done research knows that screening logs are very badly completed. We randomised 509 patients, 253 to usual care and 256 to the heel casts, and we got outcome data on 213 and 212. I'll take you through the results. These are the baseline characteristics. What I can tell you is that there was no difference in baseline characteristics between the two groups, so we'll just look at the group combined so that you are aware of the type of patients that we had in our study. So the average age was 67, which is actually the average age of any ulcer trial in diabetes. and 2/3 men, as always, in a diabetic foot clinic, 2/3 of them are always men. We wanted to know about their immobility, and 45% of them had no degree of immobility, and of the 55 that had some degree, the majority of it was walking with assistance. Very few were bedbound. And I think this is probably not the type of patient that we often see with heel ulcers, but I think those very frail patients didn't have capacity. So we've probably got a slightly fitter group than we would normally have in clinical practice. The majority of them had type 2 diabetes, and they'd had diabetes for a significant amount of time. And they were a multi-complex group of patients, as we always see, with cerebrovascular, cardiovascular, renal and eye disease. So not an unexpected group of patients. They were about evenly distributed left or right, and whether they were on the plantar, the medial, lateral, or the bit that we couldn't describe, which we called the heel tip, was about even. 34% of them, you could actually feel both pulses, so they weren't particularly ischemic. We had a problem with ABPIs, and we didn't actually get them in 30% of patients, but they weren't a desperately ischemic group. And 64% of them, as you would expect, had a degree of neuropathy. And at randomisation, actually 2/3 of them were over 1 square centimetre. We would only take them above 25 square millimetres. Straight on to the results. 37% healed in the usual care arm, 44% in the intervention arm. That was not statistically significant. The difference was only 8%, which wouldn't have been clinically significant, let alone statistically significant. So there was no difference in healing in our primary outcome measure. And just to ram it home, here's the Kaplan-Meier curve showing absolutely no difference between the two groups. And if you're still not convinced, and believe you me, there were nurses who were part of the trial who were still not convinced, this is the change in ulcer area over time. And I think that one is probably the most convincing. There was absolutely no difference between the two groups at all. In terms of any other outcome event that we could possibly drag out of this, there was no difference in minor amputations, no difference in major amputations. This one particularly interested me because I was actually slightly concerned that the heel casts created an environment that would promote infection because it was left on, but actually there was no difference in infection rates between the two groups. That disproved my own personal bias. There was no difference in hospital admissions. There was no difference in trips or falls, which is a very important outcome in any offloading trial. There was no instance in new ulceration on the target foot or on the other foot or in revascularization. So no difference in any outcome measure at all. Pain. These were the 4-week pain scores, and you can see there was no significant difference between the reduction in pain scores between baseline and 4 weeks, or between baseline and 24 weeks between the two groups. So that description of prompt pain relief wasn't borne out in the study either. And just to tell you about the costs, there wasn't actually significant cost between the two groups because the majority of the costs were actually in the staff doing the dressings. The materials is actually quite cheap, but the total cost for a period of care was £2,472.67 in the usual care arm and £2,759.16 in the intervention arm per episode of care. So that there was no difference between them, but actually that just tells you how expensive this is. So in a summary, despite our early promise in a previously published uncontrolled series, it was not possible to demonstrate a clear benefit from the use of the heel casts, in addition to usual best care in this well-conducted randomised observer blind trial. So what are we left with to treat heel ulcers? Well, we're left with what we considered best practiced care that was done to these patients in addition to the heel casts. And that was making sure that the wound is visualised regularly, as much offloading as you can manage, particularly if the patient's in bed, sharp debridement if appropriate, appropriate dressing products, treatment of infection, optimal glycemic control, revascularization if necessary, and continued close observation. And I think if we did that, and not everybody does, then we would be better off than we are. And I'd like to thank all the people in all the centres who helped us with this, because it was an enormous piece of work. And thank you for your attention.
Thank you very much. We do have time for one or two questions.
Fran, thank you very much. It's so interesting when you do a big trial and you do not find the benefit. I gave a presentation on a similar theme with something that was magical and would heal ulcers. And the first question was, where do I buy it from? And it was the same results that you had, which is it doesn't work, move on. But it's so attractive. And have the colleagues that you've mentioned, have they really let that sink in? Or do you think we still look for that magical one thing that if we add in, it'll all be all right? Because it's so attractive.
This was very attractive because it's quick and easy to use, 10 minutes, very cheap. And so, if the size of the difference was as that pilot showed, this would have been enormously attractive. But I think you're right, Andrew. What you're trying to say is this is a complex subject, and I don't think any one item, there is no one magic bullet. I think we're looking at complex interventions, not single interventions. What I don't know, and it'd be interesting to go back, is whether any of the centres are still using them. Certainly it was dropped instantaneously in my own centre. Once the podiatrist saw the results, they just shrugged their shoulders and threw away the soft cast. Well, they didn't actually, we use it to tie on the offloading. I don't know whether any of the others, because there was sort of horrible gasp in the room when we presented the data, because I know there were trialists who were absolutely convinced in their own heads that it did work, as convinced as I was that these heel casts caused infection. So I don't know whether it has sunk in and they're moving on. But I take your point that I think it was probably naive to think that a single intervention will make a massive difference.
Thank you. Yes, there's another question over here, Alison. It's just next to you, the cube.
So it's not my specialty, but it makes me think, because we've used soft casting before and the pain relief did seem dramatic, so I am very surprised by those results. But it's still an intervention, so it's it has the same results as another intervention. So the point is, what's the intervention, I suppose, but also how do you put an intervention in place that it facilitates something different for that patient? So is there something that's different about soft casting compared to offloading that has some benefits, even if the outcome would be the same, but it's more about lifestyle or mobility impact or other things? Maybe the soft casting is slimmer.
So what we said was, and I perhaps didn't labour this point, that actually usual care included offloading. So if whatever they would normally have done, we added the soft cast to it. So this wasn't a soft cast versus air cast walker trial. This was soft cast versus usual care. So if the clinician felt that an air cast walker was appropriate, despite the fact that there's no evidence that it actually helps, because these soft casts could be incorporated within that. So we were looking to something in additional to usual care, because we know what usual care does. It creates wound healing in 200 days. So we were looking to additional benefits. What I don't know is whether in the original pilot, those patients weren't offloaded, weren't treated as they would be. So what we've not done is soft cast versus air cast walkers. What I do know is that these patients, almost half of them were relatively immobile, and we do get incredibly concerned about offloading in patients, even who walk with a stick, because of balance problems. The vast majority of them are neuropathic, so they don't know where their feet are. Many of them have got retinopathy, they can't see where they're going, so the only sense that's keeping them upright in space is their ears. So you take away two senses and the risk of falls goes up. So many of them would not have had offloading, and soft cast might have been the only thing they could have been offloaded with, because that will then fit in an orthotic shoe or something like that. So, but it didn't matter which way we cut the data, old or young, men or women, type 1 or type 2, and we did do, a number of sub-analyses, all pre-specified, of course. It didn't matter which way we cut the data, we couldn't find a difference in any subgroup.
Right, any other questions? In that case, I think I'll thank you, Fran. That was an excellent presentation.